Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to the Voices of Otolaryngology. I am super excited today to have Dr. Yaremchuk and Dr. Woodson with us. Thank you both for making time this afternoon.
Great.
Dr. Yaremchuk, could you kindly, and I can't say introduce yourself because that would take the whole episode, perhaps let us know where you are now and what you're up to. Then we'll go to our colleague, Dr. Woodson.
All right, thank you. So I'm at Henry Ford Health in Detroit, Michigan, and that's where I've been my entire career. I'm chair emeritus there, still active in research and active in the academy and past president of the American Academy.
Great. Dr. Woodson, please.
Yeah, my credentials pale in comparison, but I'm the professor in chief of the Division of Sleep Medicine and Sleep Surgery at the Medical College of Wisconsin. And I've been here all my career, and it's great to be a part of this. Thanks.
This is a special episode for me. I firmly believe that we stand on the shoulders of giants, and you both are giants in the field. You might not think so, but I am heretofore announcing you giants in the field. The ISSS, International Surgical Sleep Society, a lot of your colleagues said, hey, you've got to do a podcast with Dr. Woodson and Dr. Yaremchuk. So let's back up. We're in 2025 now, and you're educating me, and I'll let one of you start. When did you realize we as otolaryngologists have a role to play in sleep medicine? I'm being completely serious. Was that in residency? Was that in fellowship? When was that? When the light bulb went off to you?
Well, I started actually when I was in medical school. I applied to Henry Ford Hospital and heard about a disease called sleep apnea, and didn't know much about it. Back in the kind of late 70s, early 80s, and so I went to my textbooks, and nobody had anything about sleep apnea or sleep medicine in there. I did find in one psychiatry textbook it did say sleep apnea was a rare and infrequent disease in obese men. And so then I went off to Henry Ford and met up with Dr. Fujita, and certainly changed my life, from there. So for me, it was definitely in residency, having the chance to work with Dr. Fujita, who is a great innovator and thought maker. But we kind of helped him complete his vision, I guess, in a sense.
Dr. Yaremchuk?
Well, I should tell you the surprise right now is Tucker was a resident for me. So we were at Henry Ford at the exact same time. So if you want to call it the epicenter of sleep medicine, Dr. Fujita was a fellow senior staff faculty with me, and Tucker was a resident. And I remember Dr. Fujita getting involved in this. And the first publication was about UPPP, Dr. Fujita. And the reason he even suggested it as a surgical procedure was that there was a journal, Japanese journal, and they did an article on snoring, and they talked about UPPP. Dr. Fujita, being Japanese, read it and said, this might work for sleep apnea. And he convinced a pulmonologist, a psychiatrist, and I'm going to say a sleep medicine PhD that this was the way to go.
So this is amazing. I mean, I just learned a lot even there. Let me back up a second. So the original article for UPPP in the Japanese journal, do you know what it was for? Was it for sleep apnea? And he brought it to the US? Yeah, what was it for?
No, it was actually well before the description actually of sleep apnea as a disease. Earlier at that time, Bill DeMent at Stanford was beginning to, collect data and do sleep studies, but sleep apnea was really this unrecognized disease. It was described in Italy by Dr. Lugarese. He called it the progressive snorer's disease, and kind of did work on more epidemiologic work versus sleep study work. But it was only later that it was actually called sleep apnea, named that by Christian Guilleminault, who was at Stanford. But early on, no, this was just a snoring procedure. So Dr. Ikematsu in Japan developed this procedure. There was really three parts. It was a uvula-palatopharyngoplasty, but it was really three different procedures. There was the uvuloplasty, the palatoplasty, and the pharyngoplasty parts. And they were three separate little incisions. And what Shiro basically did, one of my senior residents Sam Michelson described, he just put it all, and George Levy, he said, he just put it all together. He combined it as to one procedure. And I think part of his genius is that he looked in people's airway and said, this is not normal. I mean, really up to that point, till UPPP was described, a lot of the people in pulmonary medicine thought that really sleep apnea was a neurologic, disorder, that these people had abnormal breathing control, and they actually did not recognize that there actually were abnormalities of the upper airway. And I think that was really the fundamental genius of Shiro, was that he actually took the time to look in people's airway. He did an exam, and he observed that these people did not have normal airways, and that maybe surgery would have a role to play.
So let me say it back to you in my simplistic manner. Dr. Yaremchuk was not being facetious or full of hyperbole when she said Henry Ford might have been the epicenter of American surgical sleep medicine. I understand our colleagues at Stanford, but you said one of the residents put it together, the uvulopalatal that was originally for snoring, and Dr. Fujita recognized that it helps with sleep apnea. Is that what you're, either of you, Dr. Yaremchuk or Dr. Woodson, are kind of putting together for us?
Yeah, it was this article in a Japanese journal. Oftentimes great things happen in happenstance. And he saw this for snoring, and snoring obviously was a symptom of these patients. I think it also was that he was able to find collaborators. If he hadn't found a pulmonologist that was willing to work with him, Dr. Tom Roth, who is a sleep physiologist, PhD, and a psychiatrist also involved in this, it was that perfect time and a perfect place.
Yeah, it really was, because there weren't very many sleep labs. I mean, remember, this was the era of paper recording and 12-foot high grass polygraphs, and so getting a sleep study was not an easy thing to do. And Henry Ford happened to have this immense and great, really wonderful sleep lab facility, and so Shiro was able to take advantage of that and got, like I say, support from the people around him to move forward.
This is late 70s, early 80s.
It was early 80s. The first article was published 1982 in the White Journal. I got the original article from Ikimatsu, and I had a resident who was Japanese. Her mother actually translated it for me. And it was interesting. It was about snoring. It was about what we usually say, usually men, usually snorers, usually overweight, but fascinating to see how that transpired into what we have today.
This is
And it's interesting too that before then, remember, this was an era when the only treatment for these patients was tracheotomy. And so we did a lot of what we called permanent or skin line tracheotomies, was really the treatment for the patients. So having an alternative to tracheotomy was really groundbreaking, and it really affected the early development, and even how we defined success, and that it created some baggage as we went forward. But it really was groundbreaking to have a treatment alternative other than tracheotomy.
What a wonderful point, because when you're looking at risk benefit, yeah, sure, it's certainly worth the risk to have what I would consider minimally invasive UPPP compared to a skin line tracheotomy. Very, very well said. Certainly worth the risk. So UPPP, early 80s, I learned the genesis of that. Thank you both. What evolved next? I did my training, by the way, for full disclosure, 2000 to 2006. So you all have 18 years to bring me up to speed.
Well, the next step, really, in the scheme of things, was this definition of what was successful treatment. So again, early on, when I first started, really successful treatment for sleep apnea was getting the tracheotomy reversed. I mean, honestly, yes, you wanted all the apnea gone, but if you're able to reverse the tracheotomy, that was a successful, operation. But almost simultaneously with Shiro's development was the development of CPAP. And it's interesting that the first time I ever saw a CPAP machine, we were doing rounds one day, and we heard this horrendous noise. I mean, it was not subtle, to say the least. This massively loud blower and basically a vacuum cleaner turned backwards was running in a patient's room. And here was this person that probably was 350, I don't know, it was an extremely obese person. And with this mask on there, and they're sitting there, it's making this noise. And that was my first experience with CPAP, was that. It was no idea that it would go from there, but certainly CPAP did change the whole nature of the field and change what was the definition of success, which up to that point, a responder based on the cancer literature was a 50% reduction in tumor size. So I actually used the same definition for a responder in sleep apnea in the early publications, which was good again for getting out of trach, but was, was secondary compared to nasal CPAP. So it early became, apparent on that we needed to actually, that there was a group of people that did have a great response, but there are also a number of people that either had a partial or no response. And what were we going to do about that? How were we going to help or fix these people?
I think the other thing is that when a surgical procedure was available, it was very much if you have a hammer, everything looks like a nail. And so every patient that came in with sleep apnea got a UPPP. And what I think we spent the next 20, 30, 40 years is who is going to respond to surgery and who isn't a good candidate. We talk about precision medicine, we talk about patient centered outcomes, and we talked about that there was only tracheostomy at that time. The other issue is that these patients were miserable. They were the patients that were losing their job. They were falling asleep at work. They were falling asleep at home. Their family was tired of them. And there was really a component of this was volitional. This person was lazy. This person is not being engaged with the family. He's not wanting to work, as opposed to this is a medical condition that we need to treat.
Absolutely, that's really important. In fact, when even with the tracheotomies, people were obviously very reluctant to get a tracheotomy, but it was surprising as you'd go in there and as reluctant as people were to get the tracheotomy, once these patients were treated, they didn't want the tracheotomy reversed until they were better. It was quite an amazing dynamic. The change in health that these patients experienced was just unbelievable. Some of these were the worst of the worst at that time, and it was just amazing the effect you'd have. And then when you're able to reverse the tracheotomy through some series of surgical procedures, which evolved over time, it was really pretty gratifying.
So that's really fascinating. I like to keep these podcasts somewhat light. So this is the commercial break of levity. Do you all watch Downton Abbey? Have any of you watched? You have.
Yeah,
Okay. You didn't see the movie, the premiere Friday night?
I
So
have not.
you both have busy lives. Okay, Doctor. Okay, so I'm free. I went out to the movie and it was absolutely hilarious. There's one of the characters who said, "I'm going to read Charles Dickens," um, and it was something about the Pickwickian Papers, and then he fell asleep snoring like the Pickwickian syndrome. And my wife's a pulmonologist. We were the only people laughing in the theater. I mean, it's such beautifully done. But you're right. There was this narrative out there that there's nothing we can do for these patients.
Well, that it was volitional. It wasn't that we couldn't do anything for them. It's that this is their fault. They're lazy. They drink. They're fat. They're just awful people. It wasn't that it was a medical condition that wasn't even recognized. They were just the unemployable, the people that you didn't, Uncle Joe who always falls asleep at Thanksgiving dinner. It's just the way they are.
Mhm.
Yeah, it was really unbelievable. I was really unrecognized, forever. I mean, it was really treated as this new disease, and it's even surprising on the sleep study side of the world, like at Stanford, where they were studying narcolepsy and other sleep disorders, doing thousands of sleep studies, and they failed to notice that people weren't breathing. I mean,
Yeah,
it just people had blinders. I guess they were, we see what we look for, don't we? And this was definitely the case. And then once we started looking for it, it's now everywhere. I mean, according to the Academy of Sleep Medicine, I think uh, everyone has sleep apnea now. There's no one that doesn't have it, depending on how you diagnose the disease. So we've gone from one extreme to the other. I
sure.
think, Kathy, I don't know what you think, but
Well, I think it's an interesting time in what matters. And I think that we are now at the stage, and there's a lot of similarities between sleep apnea and diabetes in terms of the literature. And some of us, when we went to medical school, we looked at fasting blood glucose, and that was the way you knew if someone was a well-controlled diabetic. Well, for sleep apnea, many people are still just looking at the AHI and recognizing that doesn't tell the story. For a diabetic, we have glycosylated hemoglobin, we have their creatinine, we have their eye exam. And I think we're now recognizing for sleep apnea, AHI doesn't tell a story. Is it the oxygen desaturation index? Is it the time spent under a certain percentage at night when you sleep? Is it the number of arousals that cause the hypersomnolence? So what I say right now is that the exciting part of sleep medicine is that we're looking for the glycosylated hemoglobin for sleep apnea.
Yeah.
I mean, that's what's exciting about it is it really is still an emerging, I feel like a new field. I mean, it's been a fascinating thing to be. I mean, I don't know if you talked about standing on the shoulders of giants. I mean, I feel like, I'm just a midget, but I was first in line. So I guess, that made a difference, right? But it is such a new field and there's so many new things and exciting things for people, for surgeons, for scientists to really discover and to really help our patients and to really advance our knowledge in this area. It's just really beginning a lot. So kind of going back, you asked earlier about the story of where we went from UPPP. Well, kind of one of the next step was actually kind of saying, well, geez, this is this multi-level disease. We'll try to do a better job of patient selection. So we'll do all these fancy exams. So we'd have a very complicated exam with Mueller's maneuver and other sorts of ways to try to stratify the airway to identify who had isolated palatal obstruction. But then we kind of realized that, well, geez, only a very small percentage of people had isolated palatal obstruction. So then we evolved into this multi-level surgery arena, which is when I really got involved with Dr. Fujita. He started looking at doing glossectomies and actually doing tongue reduction procedures because that was what was available. And so we kind of evolved and diverged into two different groups. There was the Stanford group working on skeletal approaches to address what was felt to be this multi-level obstruction. And then the soft tissue approaches, which was the kind of glossectomy, lingual tonsillectomy, approach.
And I think the other thing is that we now recognize that maybe it's not just an obstructive phenomenon, but it's a collapsible phenomenon. And so for some people, it is like achalasia of the esophagus. It's an airway. I don't want to call it a stupid airway, but an incompetent airway that closes even when the patient's awake. We talk about people. I was sitting next to somebody in a movie and I could hear them breathing. They were snoring while they were awake. And some patients even tell us that. So that idea of precision medicine, recognizing which patient has an obstruction and which patient has a collapsible airway or one that needs help in keeping itself open and patent.
It's really fascinating. I wrote down skeletal surgery and soft tissue, and now you're starting to get into when I started training, and these were somewhat morbid surgeries. But when you first started, you were comparing to tracheotomy. So yes, UPPP certainly, but now we're starting to compare to UPPP and CPAP. Well, now we've got to think a little bit.
This episode of Voices of Otolaryngology is brought to you by
CPAP works for many. We're here for the rest. With over 100,000 patients treated, Inspire Therapy is expanding across ENT practices nationwide. It's a minimally invasive, outpatient procedure for moderate to severe OSA, implanted in less than 90 minutes. Over 300 million Americans have insurance plans that cover Inspire Therapy. Close the OSA treatment gap with Inspire Therapy. Learn more and review important safety information at inspirefortherest.com.
We haven't yet gone into board certification for sleep medicine for ENT, but when I first sat for those boards, that was 2008, and pulmonologists were telling us that surgery had no role in it. And then in 2018, when I had to take my recertification, studies had come out that said using CPAP did not prolong life. It did not decrease morbidity, mortality. It did not decrease heart disease. And all of a sudden, the tables were turned. And I'm going to say ENT were no longer the sad people saying we have nothing to offer.
Yeah, certainly. The environment has changed a lot. It was definitely we went through a very hostile period for a significant portion of my career. And I think some of what Kathy and I did during that period of time was, we kind of were placeholders, so that things could advance so that otolaryngologists could, really participate in sleep as they do now. Because there was a very kind of a rocky period when we were certainly people wanted to exclude, surgeons, from the mix. But we have a lot to offer, and I think, in a lot of different ways. Being involved in sleep medicine it's been a very gratifying career, in many, aspects, both from the academic part, but just how we had a different view to how we treat our patients than some of the other specialties. I think it really can be beneficial for the patients as well.
Yeah, you used a funny word there, placeholder. I'll use a more honorific word, trailblazers. I mean, now you're starting when I finished up in 2006, and obviously you both were very well established by there, speaking to packed standing room only. And we remember you all as trailblazers helping us think about the role of otolaryngology. I'm thinking back to 20 years ago to those meetings. So I do appreciate that you all were fighting to make sure otolaryngology stayed relevant. So we had the skeletal pathway, and then we have soft tissue, and then bring me up after that because that might be probably where we are current state. Or no, did something happen from them to where we are now?
Yeah, it certainly changed. So then we went from actually more reconstructive surgery on the airway, which I still think has, a role, to actually, looking at other modalities. Obviously, now we're looking at neuromodulation as being really a major contributor. Years ago, I was involved with Inspire when it was part of Medtronic. So it started out as a company with Medtronic. And so, we're doing this study and we're all ready to enroll patients. And they had some patients in Europe and the electrodes fractured and broke. And so they had to do a redesign of the device. And at that point, Medtronic decided to drop out of the business of neuromodulation. And in fact, they were going to kill the program altogether. I actually had a doctor come and visit me, and we're sitting there operating, and he made this side comment. He said, I was just a part of a panel, and they were talking about doing neuromodulation, about doing nerve stimulation for the treatment of sleep apnea. And we all just thought it was not a very good idea. And he was kind of asking for my blessing, my agreement of that. And I remember at that point, I immediately left the operating room and got on the phone. And I happen to know the president of Medtronic ENT. I happen to know him personally. And I called up this individual and I said, "You're not actually listening to these people, I hope." And there's this long, pregnant pause. And I ultimately, very shortly thereafter, went to their headquarters. And we spent a week kind of talking about where the future of sleep apnea went. And ultimately, I think, Inspire kind of ultimately got supported out of that, some ventures, but it was really kind of a wild idea that went out. But sometimes wild ideas are good ideas, and this seems to be made a real, meaningful difference of saying, let's not reconstruct the airway, but let's work on the physiology. Let's work on the muscle tone side versus the structure side.
Dr. Yaremchuk, you'd like to add to that? We went from skeletal soft tissue to neuromodulation, which is just burgeoning now, not just Inspire, but other companies in the space thinking of that. Dr. Yaremchuk, any gaps to fill in there? Your thoughts?
Well, I think it's a next step. It's not a gap, but it's the pharmaceutical. Tirzepatide has now been approved for treatment of sleep apnea. And if we know that a third of our patients are obese, and that, we all know that when patients lose weight, they tell us, I stopped snoring, I feel better, those kinds of things. And so now we have GLP-1 medications that are going to take care of that population. In the past, those were approved for diabetes, they were approved for heart disease. They're now approved for sleep apnea. We also talked about that subset of patients that have a neuropathy of some sort. A problem with the musculature such that it does not contract on inspiration to keep the airway open. And there are now drugs that are aimed at that as well. And at one time, I remember a patient, they would come in once a year to see me, and they'd say, well, is there anything new? And they go, is there going to be a pill to treat sleep apnea? And I would laugh. I'd say, oh, that's silly. We're never going to have a pill to treat sleep apnea. And here we are. We have a pill to treat sleep apnea. So when we talk about it, we've gone from tracheostomy, neuromodulators to medications. I think I keep going back to this precision medicine, and patient choice. What is the right treatment for a patient? What will work for them? And they all require patient adherence. If you have a neuromodulator, you still have to turn it on at night. If it's going to be a medication, you're going to have to take the medication. So a lot of patient choice and a lot of patient counseling goes in to treating these patients appropriately.
Yeah, I think it's going to be more of a work. I think actually at one point in time, like I say, with the UPPP, when Dr. Fujita started, you had the hammer and everything was a nail. And now we're going to have many different tools to treat this. And it's going to, raise the bar, actually, I think, in treating these patients well. And I think the otolaryngologist is really, well positioned to actually help, direct a lot of these treatments, because I think it will be really a multimodality, atmosphere or environment. Some people may benefit from, some tonsillectomy or nasal surgery or some sort of other more conservative interventions. I think the day and age of probably doing massive transoral robotic surgery is probably, is probably waning. But I think the role of doing more sophisticated interventions is just beginning. I think it's going to be a tremendous area of growth and learning to how to integrate use of these medications with other treatment modalities that we have now.
I think it's also the opportunity to think about it that it's not one and done. And we always, as surgeons, it either works or it doesn't work. Well, it may work partially, and then we're going to add something else to it. When a patient has high blood pressure, it's not uncommon to have more than one medication to treat it. So we may want to think about multimodality. Yeah, we're going to use some medication. Yes, we're going to use surgery, and even exercise. We haven't talked about that, but there are in many countries, and there's good research to say having muscular exercises, physical therapy for the oral pharynx and for the upper airway muscles can well help with this as well.
Wow, those are awesome. I'm not familiar with that literature. I look forward to it. I just have three more questions for you all that I promise will get you back to your clinical busy practices. I have been convinced, and I've been seeing in my 1 year on the job, sleep surgery, sleep medicine is huge. It really is absolutely taking off. Some people say the nose is something we need to focus on more when we look at multi-level sleep surgery. I didn't mean to bias you or give you a heuristic, but can you comment that? Is that overly simplistic? But they feel that we have a lot more to learn from the nose about multi-level sleep apnea, perhaps, than the oral cavity.
I'll let Kathy go first because I have some stronger opinions, but I'll let her go with that first.
I have seen patients, and I'm going to say I think targeted intervention is important. I think there is literature, physiology. You have a blocked nose, your lungs react differently, airway reacts differently. So I think there's definitely some truth to that. I've also seen patients, if the mouth drops open because you're a mouth breather, you narrow the oral pharynx, and so that causes problems. So I think we have to look at holistically to see, and I think in some situations it makes perfect sense, but it's each patient being a little bit different.
Yeah, I think the nose is really pivotal. I mean, for a couple things. One is that I think a lot of people with apnea, the nature of their craniofacial structure and the anatomy, that they have abnormal nasal resistance. But I will also say that just treating the nose does not treat sleep apnea. That being said, I advocate, and I think nasal obstruction is its own sleep disorder. When you look at the impact of treating someone's nasal obstruction has on their global sleep, be it their quality of sleep, insomnia, just how restful sleep is, the nose has a huge role independent of sleep apnea. So I always think that we probably under-treat the nose, but I think it's two different things. There's the issue of the nose and sleep apnea per se, which has a small role to play. Like I said, it can have an effect in a subset of patients, but the nose in itself has a huge impact on, I think, global quality of life, and especially sleep-related quality of life is really, really a big part.
Yeah, really appreciated that. I'm a walking example of a rhinology case study. I mean, you see that polybeak deformity, nasal valve collapse, septal deviation, swell body. I've got it all, folks. So
I think that's part of it is you have to be I mean, it's not just septoplasty or
that's
turbinate
right.
reduction. I think it is, a more comprehensive treatment of the nose and nasal disorders. Certainly Tim Smith, I mean, they've shown, the impact of chronic sinusitis on sleep quality is enormous
Yeah.
and probably way underestimated.
I promise you just two more questions. I can't get enough of this conversation. So who would have thought y'all are training together? Dr. Yaremchuk's perhaps a junior attending, Dr. Fujita, senior attending, and who would have thought we'd be talking about neuromodulation, site of lesions? Dr. Yaremchuk, I'm going to give you a lob here, an easy one. You mentioned therapy, oral therapy, exercises as the future. What do you see when you take your sleep crystal ball? Who would have thought of neuromodulation? But I really like where you're going, Dr. Yaremchuk. Maybe there's training, other things we can do. But what do you see out there with the blue ocean? What is out there that's innovative, novel, that might be the next 20, 30 years of sleep medicine?
When I think about it, I keep going back to this is what really makes good sleep. Is it, lack of, arousals? Is it airflow? Is it, the problems with actually holding your breath? And the things we've been measuring don't correlate with anything. You can have severe sleep apnea and no hypersomnolence. And so the quality of life and sleep, what are the things that matter when we do a sleep study that make a good night's sleep
Mhm.
and people are happy?
And if we figure that out, Dr. Yaremchuk, then we can fix it. I mean, that's
Exactly.
very well said.
Exactly.
Dr. Woodson, you want to follow your junior attending there?
Yeah, well, yeah, I agree. As I was a mid-level resident, I don't know exactly, yeah, I absolutely agree that diagnostics and finding out who is sick and who's not, and then you can decide how aggressive to be and direct the treatments more appropriately. I think on the breathing side of the world, we always say, geez, it would be nice if we could prevent, the development of this. What can we do on the pediatric side that would actually maybe prevent the development of sleep disorder breathing? But I think, we're seeing all these different tools come in, and it's going to be fascinating to see how we can really implement them, especially things like control, the weight management and obesity control. Can we really maintain lifestyle changes over a long period of time with these medications? Um, and but certainly we have tools in our tool bag that we didn't imagine, you know, 30 or 40 years ago for sure.
Um, I'm thinking of personalized medicine. Dr. Yaremchuk, you use that word several times, and it's really hitting home to me. I think of my Aura ring, and I think about when do I have sleep apnea, and if I eat after 8 o'clock, if I have dessert after 9 o'clock. So you're right. There are other factors that contribute to sleep just versus surgery. Two more. One comment, then a question. I told you about my wife, pulmonary critical care. So during residency, my shirts were tight and they were 15-inch necks. And she said, you've got to be like a 15 and a half. Why don't you get it? And without batting an eyelash, I said, well, 15 and a half neck size correlates with sleep apnea. She goes, so you just wear tight shirts? I said, yeah. But there's a lot of contributors, and you all probably came up with that neck circumference. So I appreciate you all. I didn't know you trained together, so you've got to give us one funny story about each other. It is so fun when I think of, I know, Dr. Yaremchuk, I'm sure Dr. Woodson kept you quite busy with some fandango ideas, or he must have scared you with doing the vacuum the wrong way. It's so fun when you think in the 70s and 80s, you all trained together. And look now, almost 45, 50 years later, you've advanced our field and our specialty, and you both have emerged great leaders. Give us a funny story that maybe a lot of people don't know. So let's do Dr. Yaremchuk first, and then Dr. Woodson. You'll follow your junior attending.
Okay. And mine isn't a funny story. It's a sweet story. I was able to go to Tucker's wedding. And so, one of the biggest honors an attending can have is to be invited to a resident's wedding. And I believe that. And now, like you said, decades later, we are still friends. And he still calls me when his father-in-law needs to have a referral for something and vice versa. So those kinds of connections, one during training, but have sustained itself at the academy, at the ISSS, and our families together.
All right, but that's not good enough. I'm going to push you. Give me one thing, maybe one paper that Dr. Woodson wrote that you said to yourself, God, I trained this guy. What is he thinking? Or where you don't always agree, right? This is a hard field and there's a lot of opinions and it's been evolving.
Well, I will say that Tucker tends to have an idea a minute, and he tends to publish each one of those ideas.
Yes.
And if we were to go back over all of those articles, some of those I'm sure he would like to bury. And that's as much as I'll say.
Polite. I love it. Dr. Woodson, a funny story about your junior.
Well, yeah, for Doug, it's been, residency for me has been a long time ago. It's like, so trying to remember something. I mean, I do remember, Dr. Yaremchuk was a very qualified, general otolaryngologist, did a lot of otology. And, quite honestly, I was, scared to death of her actually for many years. Is pretty impressive, all the things that she's done. I mean, certainly I remember, probably when she wrote her book, years ago, I'm sure I was probably the last one to get the chapter in. I'm sure she was, had a few, unfavorable words, and, wrote a few unfavorable thoughts, dealing with my chapter for her book, but really, it's been a great experience. I mean, over the years, we've been able to collaborate and maintain, the linkage there at Henry Ford. I mean, she's just done such a great job, as the chair there has taken the program, just to really exceptional levels. And so honestly, unfortunately, I can't think of, any, bad stories on any meeting or anything that's really been, terribly, unfortunate. There's been other people that, where, we've been out late at night, and gotten lost wandering in the ruins of Rome and stuff. But unfortunately, I never did that with Kathy. So,
well, this was an awesome video cast. I loved learning from you both about the history of sleep medicine. I consider myself academic and certainly steeped in the history of otolaryngology, but I see my colleague Jackie Cole, who's our director here of communications, nodding her head. This was awesome. Thank you so much. And I loved the futuristic and how you both really have helped cement otolaryngology as the center of sleep. And I think that's much gratitude on behalf of our specialties. Thank you both very much.
Thank you.
Great to be here.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.